So welcome, my name is Shruti. I am a paediatrician. I've been working as an NHS doctor for over 6 years, and I have a son called Jason who's just over 2 years old now. So Jason is the reason why I started my Instagram page at the Children's Medic, because despite being a doctor, I still had a lot to learn as a new mother. I soon realised pretty quickly how daunting being a new mum was. And despite the fact that I had all this medical knowledge, I just didn't know how to put the two together. So now that I've gained a bit of parenting, I guess, experience, I wanted to bring together my medical knowledge and that experience, tie it nicely together, and just help other mums because it's so overwhelming. I was filled with anxiety. I found it really scary. And if I can just help one of you today, just feel a little bit more confident in recognizing what's right and maybe what's wrong with a newborn, then my job here is done. So just a little disclaimer before we start. So I am hosting a webinar, so I'm giving information, but this is not personal medical advice. So this does not replace being seen by a competent doctor in person. If you're worried about your child, that's what you need to do. You need to take them to be seen. I will be hosting a 10-minute Q&A at the end. I cannot give direct individual answers, so I cannot give personal medical advice, but I can answer the question in a general manner, and that's just to protect me as a doctor and also you as, and your baby, because you need to have that doctor-patient relationship. Okay, so that nitty-gritty bit is done. Now to get started. So we've got 6 topics I'm going to cover today, and I've got my nice iPad here. So we've got topic 1 is fever. Topic 2 is breathing. Topic 3 is jaundice. Topic 4, tongue-tied. Topic 5 is reflux and colic. And topic 6 is newborn, vomit, and stool. I could talk about each one of these topics for an hour, each one. So I'm trying to fit 6 of them in 1 hour. So bear with me. I will be as concise as possible, but actually go at a pace where you can digest what I'm saying, because I think we're all exhausted. We've either pregnant and got pregnancy insomnia, or we've got newborns or little ones and we're shattered. So digesting information is not as easy when you're exhausted, but I will do my best to keep you all very engaged. So why don't we get cracking? And you can message me questions as we go along. I'm more than happy to try and answer them, or I'll do it right at the end. So topic 1, I'm going to talk about babies and what's normal for them in terms of fever and what's not. So most babies have an average temperature of around 36.4. Now, when it comes to measuring their temperature, there's just a few things that are quite useful as a parent to know. I've got my little prop here. This is baby Amelia for today. So we're going to use Amelia to help show how to measure a temperature. So the first thing is, if your baby is under 4 weeks old, you want to use what's called an electronic thermometer. And I do have a picture that I will share with you guys to show you what I mean by that. So it's not as fancy as, your sort of new age thermometers. We've got lots of pictures here. This is the one. But it's really useful, okay? And the reason why I wanted to show you this, I don't have one with me, is I wanted to show you where to place it. So you would place it here, so underneath the armpit, but what you would do is the tip of it would go underneath the armpit. You want to squeeze the arm against the chest wall like that, and that gives an accurate reading. So you would keep baby flat and you would keep it in there. They'll wriggle around, that's fine, as long as you can keep the arm quite close to the chest. That would give an accurate reading. Now, all of these thermometers, they come with instructions. I mean, I don't know about you, but I don't really have time to sit there reading them. So hopefully this is just useful enough for you to know. But things to remember when you're measuring a temperature. So the temperature of the room, so if you're in a really hot room, that could impact it. If your baby's overdressed with lots and lots of layers, that could impact it. I wouldn't say undress your baby and let them cool down and then do it. I would say undress them, do the temperature, and dress them again. Because what you don't want is for your little one to become quite cold. Okay, so I will stop sharing that picture now. The next sort of thermometer I've got is the Braun-in-Ear. So it's called a tympanic thermometer, which goes in the ear. Now you can use this from around 4 weeks of age till 5 years. I'll go through how to use it. I find it really useful to know. So there's an on button here, and then this little baby crawling, if you click that, then there's different ages that you can select. So on here, there's sort of, I think it's 0 to 3, and then it goes up from there, 0 to 3 months. So the important thing about the in-ear temperature is that you need to have it right in the right position, and to be there for a couple of seconds. Now, if your baby's unwell, if they're uncomfortable, or if they're screaming, a couple of seconds is a long time to keep them still. So a few things I would suggest with your little one to help them is, if you are breastfeeding, that's a good way to get a temperature. If, say, you're bottle feeding and you've got the bottle in, they're quite docile when they're feeding. That's another way to get a temperature. If they're really irritable because they're unwell and they're just really ratty, sometimes the best thing to do is to just pretty much hold them however you can, whether you do it by yourself or your partner helps, but you sometimes have to stabilize the head a bit, and somebody else can do. So if I held, this is baby Amelia, and say my partner came in and then did the temperature, I'm keeping the head nice and stable so we can just get that reading really quickly. And you do find when you go to A&E, actually sometimes for a newborn, just having their temperature taken is probably the worst bit, because no baby likes to be held in any sort of position. So that's just useful to know, to get a good reading with the in-ear thermometer. Get all sorts of good deals with these on Amazon. I think we got ours at a really good price. Okay. When you go into hospital, they might use like a little plastic looking thermometer where they place anywhere. So don't worry about those. Those are disposables. It's for the hospital setting. The one thing I would say is steer away from the forehead measuring of temperatures. I know that's what's being done during lockdown and COVID right now, but for little ones, that would not be recommended. I have got lots of handy notes, which I'm going to show you, that I'm going to be looking at and flicking through. So if you see me looking down at all, it's because I've got my references here. But so what I would say is, when you do get your child seen, if they have a temperature, there are a few things that are done. And I will actually tell you about them in a minute. Let me tell you first what a temperature is for a little one. So if they're between the ages of 0 to 3 months, a temperature of 38 degrees or above is cause for concern. And what I mean by that is take your little one to A&E. If they are, I know this is newborn, so probably not relevant, but for later, just so you know, between the age of 3 and 6 months, if their temperature is 39, just that 1 degree more and above, that's cause for concern. So the number to remember is 38, and that's when we start to think, what's going on? Pediatricians like myself want to see your baby. You're not disturbing us. We have a very low threshold for seeing little ones, because we need to act quickly when a little one's unwell. So this changes later on as your baby grows. Say your 6-month-old had a temperature of 38, so not 39, and they had it for just a few days. You can watch and wait. You can give Calpol using the instructions on the bottle. You can see your GP. It's not a straight to A&E situation unless you're really worried about your little one. So it's just to sort of gauge when you need to go and see someone, what you need, and what happens when you go there. So we look at your baby on the whole. So we will do a full examination, take some measurements, and ask you a few questions about what's been going on, how's the feeding, how are the nappies, how are the wees, how's baby been generally alert, drowsy, active or not really, how's sleeping, everything. So we want to know absolutely everything. If you've got videos or you've taken pictures of rashes, you've got videos of strange behavior, like we want to see it, so you take them. And what are we looking for? So we're looking for infection. So a fever is your child's way of showing that they're fighting an infection. And with little ones, we have a very low threshold for different infections. The first one I'm going to approach and talk about is meningitis. And I know, Olivia, you wanted me to mention meningitis and just cover it. So I'm going to do that quickly. It's a big topic. So meningitis is one of those sort of infections where we do have a low threshold for with little ones, especially if they're drowsy, they're not quite alert. That tells us that neurologically something's going on. In hospital, the only way to sort of detect that is by doing something called a lumbar puncture. I won't go into explaining what that is. It's just so that you know that's how it's diagnosed when you go into A&E, for example. And the other things we would look for are a rash. So the term is a non-blanching rash. That might mean absolutely nothing to you, so I will explain it. So I've drawn a few little, oh, they're probably disappeared. I drew a few purple spots on Amelia, poor thing. And I was going to show you what the glass test is. And you may have heard of this already, but if you haven't, this is what it is. So if you notice a rash on your little one, you can get a glass, a clear glass, and you can push that glass against the skin of your little baby. Now I'll do it on maybe my hand. And what you should see when there's a spot there is that that spot will sort of go pale or go away. And when you release that pressure and remove the glass, the colour comes back to that spot. So if you push that glass against the spot and the spot still stays red and you can see the redness through the clear glass and it's still there when you take it away, that's what we call a non-blanching rash, which means it just doesn't disappear. That is one of the key signs in meningitis. I'm not sitting here saying to you, you should know it, or you should know that test inside out, and you should know how, you should be able to determine whether that rash is disappearing or not. It's a useful tool for you to have, but if you can't figure it out, or you can't decide whether it's disappearing or it's still there, because it's not that easy, don't worry, that's not your job, that's our job. If you're worried about your baby, bottom line, and you think something's really wrong, you need to get them seen, especially when they're so little. That is the bottom line. So that's meningitis in a nutshell. Other things you would look for are sort of infections, so chest infections, where the baby would be breathing quite fast. Urine infections, you'd have a temperature, maybe some vomiting and irritability. But on the whole, most babies, when they're really unwell, have various different things. They could have irritability, poor feeding, fewer wet nappies, and a rash. Lots of different things could be going on. But a number to remember is 5. So if a temperature that is below the numbers I've said that are cause for concern is going on for 5 days and is not getting better, that is when we really want to see you, because we need to exclude anything serious going on. So say, for example, your 4-month-old has a temperature of 38 and after 5 days it's not coming down. You need to come to A&E, because we want to see you and do some investigations to see what's going on. Okay, so that's a lot. Now, an overall sort of message to give you is that most babies and most infections are viral, and a sort of common combination that you have with that is usually a bit of a temperature, like a low-grade temperature, we would say, and diarrhea and a rash. Those are like 3 things that you kind of think, oh, that baby's got a bit of a virus, they should get better. And most babies, after 2 to 3 days, do get better. A very common concern that I get from a lot of parents is vaccinations, and sort of, vaccinations cause the temperature. Absolutely. That temperature that is caused by a vaccination should generally disappear 2 to 3 days after the vaccination. If you find that it's persisting, something, and your baby just doesn't seem quite right, something else could be going on. The chances of a vaccination and another infection hitting at the same time are quite low, but just to keep that in mind, that if you know the cause, the vaccination, and if there's a fever after a few days, it should begin to settle. And I know a lot of people advise about Calpol. I, for one, definitely say after a vaccination, if a fever develops, yes, definitely give Calpol as per the instructions on the bottle for the age group that your baby is in. Okay, so what do we look at when you are seen by a doctor and we're really worried about your little one? And your little one's got a temperature. What are we looking at? So we're looking at the baby on the whole. We'll look at the skin colour. Is your baby pale, mottled? We'll look at the breathing. Is your baby working hard to breathe? Are they breathing quite fast? Are they breathing in and out quite deep? So that's like quite shallow breathing. We'll look at other things like their circulation. So we may press down on their skin for 5 seconds, release, and see how quickly it takes for that patch to become nice and red again. So we look at how quickly the blood is flowing around. And what we want to exclude is the word sepsis. So we're assessing for signs of sepsis. So that's just a really That's an infection that's managed to get into the bloodstream, so it would affect things like your circulation. Other things we look at are the fontanelle. So there's a little dip in your baby's head here. Obviously, this is a doll, and they don't have that dip. I would not recommend assessing your baby's fontanelle. And even as a medical professional, it took me a number of years to get used to what is a normal depth and what is not a normal depth. What I'm going to just say is purely for information's sake. If your baby's dehydrated, sometimes that fontanelle, which already is a bit of a dip, would dip a bit further. If we're worried about an increased pressure in the head or the brain because of something like meningitis, that fontanelle, that dip, would become a bit of a bulge. Now, that's just purely for knowledge. I don't expect you as parents to understand how to assess the fontanelle, nor do I recommend you go around prodding around that area and doing anything with it. It's just to know so that you're informed. And that's another thing that we would look at. We would look at how active your baby is. Are they moving all 4 of their limbs, or are they really flat and just not responsive? So we would look at how alert they are. We would listen to their cry. If it's a really high-pitched cry, that's very unusual, a weak, high-pitched cry, we know that something's not right there. And of course, you can look at things like feeding. How's that been going? Have you been managing to feed? So I've just described how we, as healthcare professionals, assess your little one when you come into hospital. We would do different things, like taking a measurement of the heart rate, and we'd assess the breathing, measure the respiratory rate, and of course, measure the temperature. So I will leave Amelia there for just a second. So that is fever in a nutshell. Most of the infections that your little one's going to have are going to be okay and are going to be managed by you at home. But if you have a newborn between the ages of 0 and 3 months and they develop a temperature of 38 and above, low threshold to be seen by a healthcare professional. Okay, I'm going to leave fever there. If you have any questions, drop me a message. Oh, we have got a few questions. Let's see if I can. Is the brawn in ear one essential? Absolutely not. You can continue to use the thermometer under the arm. That's absolutely fine. A lot of parents just like it, I think because it's digital, and I bought it because I thought I needed it as well. But a good old school electronic thermometer is absolutely fine, Michelle. Okay, number 2, breathing. So newborns, they breathe through their nose and they're very noisy. And I remember when I had Jason, I couldn't sleep because I was listening to him breathing, 1, and it was a new sound. And 2, I think it's sort of built into us to want to know if our child's breathing at night, especially when we're a new mum or we've got a new baby. We need to know that that little one is okay. So I think a lot of sleep has been lost with parents and their little ones just looking to see if they're breathing. Now, there are a few things that are useful to know. So what's normal and what's not. So we know that they breathe through their nose. We know that at night they can actually make lots of different sounds because they have what we call periodic breathing cycles. So they can go from being really shallow and fast to deep and slow. So that can change. And what is nice as a parent to be able to do is to look, listen, and feel. So if you just want to, because you're interested, those are 3 things you can do. So I would undress your little one, lay them nicely on their back, and you can play around with them, but just look. So you would look at their chest. If you see that their chest is sort of going in like that, quite deep, and breathing feels quite laboured, that is your baby working really hard. That means something's going on with their breathing, okay? That doesn't tend to happen. The other thing that happens when they're trying to work really hard is it goes in here, which is what we call indrawing, but they also become abdominal breathers, so they push their bellies out. Now that's very noticeable. In normal situations, you might have slight variations with the breathing, but you'll see your baby breathing nicely up and down, up and down. The other thing you can do is put your ear to where the mouth is, and you can feel the breath against your face and you can hear the breath. So these are just things to know. That's what we get taught in basic life support. So if you're interested and you just want to have a go and you want to figure out what's normal for your little one, that's a good way of doing it. And I can assure you with time, when you get used to the different sounds that your baby makes and you get used to the breathing noises that you might have in the same room as you when you go to sleep at night. Okay, so what is not a normal sound? So if you hear your baby grunting, so going, excuse me, I know that's a really awful noise, but it's better for me to show you. That's called grunting. That's not normal. That means they're working very hard to breathe, and you should get them seen by a medical professional. If you notice, so soon you will figure out what really fast breathing is. But if you notice that for some reason that chest wall is just really rapidly moving, that means they're working quite hard. The other thing to look at, and this is really important, is the lips. If you notice the lips are going quite blue and quite pale, that's a circulation problem. That means that not enough oxygen is going around the body. Now, these things are really rare, but I just want you to know about them in case they ever happened. Sometimes circulation won't go around the body properly because there's something wrong with the heart and it hasn't necessarily been picked up on. Again, very rare. I wouldn't say count your baby's breath, you try and figure out their rate of breathing, because it's hard. The average rate of breathing for a newborn is about 60 breaths per minute. But I wouldn't say sit there with a timer and count it. That's not what I'm trying to say. Just trying to let you know what is right, what is normal, and what's not. So other things to listen out for are wheeze. So it's a rattling noise in the chest, and a wheeze can occur for a number of reasons. So one, due to a viral infection. It is so common for new babies to get something called bronchiolitis, which is caused by a virus. So they might have a bit of a cough and a wheeze at the same time, and you might know that their breathing becomes a bit faster. Jason had multiple episodes of these, and we were very close to going into hospital for one of them, but there's no antibiotics for bronchiolitis. You would go into hospital because, as I mentioned earlier, babies are nose breathers. If they get very blocked up and snuffly here, they find it very difficult to breathe. So if you're breastfeeding, as you can imagine, you're blocking that part and their nose is blocked with mucus. So if they ever needed support for a viral infection such as bronchiolitis, because they're really snuffly and they're very small, it would be to give them feeding support. So for example, an NG tube, so that's a plastic tube that can go down the nose, can be used to give feeds, things like that. But it would be supportive management for something like that. Another cause of wheeze in a child is an allergy. Jason's got non-IgE mediated CMP, CMPA, which I will talk about later. But he was very, very wheezy as a baby, and we didn't know that that's what the cause was. We just thought he was having back-to-back viral infections. So it's just to be aware of that. So a hoarse sort of cry or a barking cough, so that's like a seal-like, really harsh cough, that could be suggestive of something called croup. And the last thing I want to talk about is stridor. So that's a really high-pitched sound due to obstruction in the airway that you will know does not sound right. Okay. Bottom line is, if you're hearing something that doesn't sound right to you, if you're seeing something that doesn't look right to you, go straight to A&E, because if it's a breathing problem, then we want to see you straight away. Oh, and a nice little tip. We talked about mucus blocking the nose. You can get mucus sort of plugs or whatever you want to say. I don't know how you call them, suctions. I bought an electronic one. I didn't touch it. If you do get the one where I think mum sucks and then basically pulls all the snot out, those are more gentle. Just be very careful with whatever you put anywhere near inside your baby's nose. I personally just like to get some running water and just kind of like squeeze the tip of the nose and just push all the snot out. I know that sounds gross. You can wash your hand after, but it's just a way of not actually physically going inside the nostrils and just clearing the nose out of anything that's blocking it. Another good thing is saline. Can you see that? Saline spray. So just a bit of salt water that you can put into the nostrils. Do you read the instructions at the back? What that does is mucus can become quite thick, so it breaks that down so it can come out, and you might notice like an hour after doing it, your like little one's nose is just streaming. We tend to do it in the bath, so there's a bit of time before going to sleep, because the last thing you want is your little one going to sleep with a streaming nose. That's really going to upset them. So that's another thing to consider with a nose being blocked. We talked about being worried about your baby, being worried about their breathing. And this happens especially at night. So I'm just going to talk very quickly about safe sleep. So we like to keep babies sleeping on their back. We don't want them on their front, where that airway, their mouth and their nose can become obstructed and blocked, because they've got small passages here. So keep them on their back on a nice hard surface, a mattress, in a cot next to your bed. So under the age of 6 months, they should be in the same room as you. Nothing should be around them. Let's just use something as an example. I'm just going to use this. Imagine this is a soft, cuddly toy, and they're on their side. If that covers their face, both their nose and their mouth, both their airways are going to be blocked, and that's what we don't want to happen. We talk about SIDS, so sudden infant death syndrome. So safe sleep methods are ways to prevent things like that happening. And just remember to dress them appropriately as well. So not too many clothes and not too little. Okay. That will help you feel a bit more confident with breathing, hopefully. And Olivia said, if you notice lips were pale or blue, would you need to call 999 or would you go to A&E? I would always, I would call 999. I would get advice, and that is basically the quickest way to get help with any sort of breathing difficulties, because if an ambulance can get to you quicker than you can get to A&E, then that's the best thing to do, absolutely. So thank you for clarifying that. Okay, I hope you're all with me still. Topic 3 is jaundice. I'm not going to go into it too much, but it's a word that's mentioned a lot and not everyone knows about it. So let me share a picture of a jaundiced baby. And just give me a second. It was right there, lots of poo pictures coming up. So we have jaundice, newborn jaundice. There we go. So this is a really obvious picture of a baby with jaundice, and it's not always as obvious. So you can see the yellowing of the skin. We can't see the eyes in this picture, but that's another very big clue. What is jaundice, and why does it happen? So jaundice is actually really, really common in newborn babies. Most of the time, it's a harmless condition that does resolve on its own. So that's most of the time. What do you see when your newborn is jaundiced? You might see that the palms of their hands and the soles of their feet are yellow. You might notice that the white and the eyes are yellow, and also their skin. Now, if you have a darker skinned baby, sometimes it's hard to actually notice within the skin whether it's yellow or not. So the whites of the eyes are a really good place to look. Another thing you can look at is urine. So a newborn baby's urine should be colourless. So if it's a sort of dark yellow, then that could indicate jaundice. And stool. So let me find the picture of stool that I wanted to share with you. So this is what, I'll go into this a bit more, but sort of greeny yellow browns of the type of stools that you would see for a newborn baby. Where pale stool colours. These are the colours that you don't want to see. So they're very pale, chalky coloured stools. That could also indicate that that there is jaundice and something's going on with your little one. Okay, so I will stop sharing the screen there. What causes jaundice? So newborns have a very sort of high concentrated number of red blood cells. When red blood cells are broken down in the body, they release a pigment, they release bilirubin, which causes the yellow pigment in the skin. They also have immature livers, which break down that bilirubin, so they're not quite there yet in breaking it down, and that can cause the build-up, which shows in the skin and the eyes. Breastfeeding babies are more prone to jaundice, and I don't know why, but they are. That doesn't mean you stop breastfeeding. Jason was breastfed initially, and he had jaundice to begin with. And the main thing with a baby that's jaundice and is breastfeeding is to get a feeding assessment done, because something could be going on there. And the minute you get those fluids, the milk flowing through your little one, the jaundice starts to improve, so they can go hand in hand. That sort of jaundice appears around day 3 of life and tends to disappear at around 2 weeks of life, but can sometimes be present for a little bit longer. Your health visitor is the person who's going to pick up on jaundice. They see it all the time. So when I'm talking to you today, I don't expect you to just notice it, because sometimes you can have your little one and you can't really tell. You see them every day. Sometimes someone else will say, oh, your baby looks a bit yellow, and you're like, oh, do they? Because it isn't always that easy to see. One way of actually figuring out whether your baby has jaundice or not is pushing down on their nose and releasing. And what you'll see is it should go from white when you push down and release to yellow. So I've got a nice yellow there that you can see on my nail, but it's not always that obvious. And it depends on the level of bilirubin that's building up in the body. So if you're thinking you can see a hint of yellow and you're not sure, ask your health visitor. They are pros at seeing jaundiced babies. Okay. So a nice little fact for you is that 6 out of 10 babies develop jaundice, so it's very common, but only 1 in 20 need any sort of treatment for it. So when your baby's born, if they've got jaundice immediately in the first few days of life, that's very, very uncommon, but quite serious. And they can need things like the blue light phototherapy. You may have seen incubators with blue lights around the babies, or they may need something a bit more like an exchange transfusion, which is a sort of blood transfusion. I'm not going to go into that today, but it's just so that you're aware of why a baby might have the blue lights on them in the ward. The other thing is, if your baby's jaundice does not disappear by 2 weeks, so Jason's didn't, we have to go and get a blood test done for him. And what they're looking at is the level of bilirubin. So they're looking to see just how high it is and how concentrated it is. And that would determine whether or not they're really worried about this jaundice or they're not worried at all. Some of the things that can cause prolonged jaundice include infection, thyroid problems, and sometimes liver problems. So that's just to be aware of. Most babies have jaundice that resolves by and large at around 2 weeks of age. Your health visitor is very crucial in monitoring that jaundice and doing feeding assessments with you. Okay. I hope that's not lots and lots of information coming your way, but that's jaundice in a nutshell. Ask me any questions you have about it. Topic number 4 is tongue tie. Now, this is becoming more and more common. Lots of research is being done into why, and there was a point where medical professionals were kind of saying, no, that's not tongue tie, no, it can't be impacting the baby that much, but now we're really, really, really aware of it. Tongue tie is, let me get the picture up so we can talk about it properly. Here we go. So it's when, can you see that thin piece of skin attached to the tongue, attaches to the bottom of the mouth? So when that's short, that causes a restriction in the movement of the tongue. So you can imagine that it can't move properly side to side. But where it really, really impacts babies is when you're maybe trying to establish breastfeeding. They can't open their mouth wide enough to get a deep enough latch. So that's when it can really, really impact them. When should your baby be assessed for tongue tie? So pediatricians like myself do something called a newborn assessment. You might vaguely remember when your baby was first born, they were taken away for maybe 10 minutes or someone came to your bedside to do an assessment, a head to toe assessment. One of the things they should have looked for was the tongue tie. Some babies have really obvious tongue tie that sort of straight away as a healthcare professional, you can see it's there, and it's, there's a scale, mild, moderate, and severe. And so it's more on the severe end, and something will be done about it quite soon. Others, it's not that easy to notice whether they've got tongue tie or not, which is why it may not always be picked up on in the first sort of couple of days of life when the newborn check is being done. What might happen later is you might notice a few things. You might notice that your little one is finding it very difficult to establish a latch when you're breastfeeding. You might notice they're really, really fussy after feeds or in between feeds, or they go on for a long time, come off, go on again. So it just feels like the feeding is not going well. They may not gain weight as quickly as they should, and you may even hear a clicking sound when they're feeding. A full feeding assessment is always required before any sort of tongue-tie division, which is where they snip the tongue tie happens, because it could just be a feeding issue rather than the tongue tie actually causing those issues. So what I would always say is, if you're worried about tongue tie, go and see your GP, ask your health visitor, because what is needed first is that sort of assessment with the feeding. And if they do need a tongue tie division, I know plenty of babies that have had them. I will explain it quite briefly. A registered tongue tie practitioner will use a sterile pair of blunt scissors, and they will essentially just snip the connection. And it takes a matter of seconds. And sometimes you can, the baby will just start feeding really well quite quickly after that's happened. They shouldn't really feel pain, because when they're if they're having it when they're quite little, between 0 and 3 months, for example, there aren't really that many nerve endings around there. There may be a slight bit of bleeding, but usually after a day or so, things resolve, and it's quite a simple and sometimes very effective procedure if it is impacting feeding. So those are a few things that are quite useful. Sometimes it's really obvious with tongue tie. I saw a baby once, and their entire tongue was a heart shape. So at that middle bit, it went in because it pulled down so tightly by that bit of skin. So there are some instances where absolutely it's needed, but it is a matter of judgment. There is a website, it's called the Association of Tongue Tie Practitioners, ATP, and they can help you find a practitioner, but always try and get a feeding assessment. And who does feeding assessments? So health visitors, midwives, lactation consultants, which are usually private, that you pay for. So all three can do feeding assessments for you and your little one. Okay, so any questions? Let me check. So this is from Nikita. She said our son was diagnosed with tongue tie and we got a frenectomy. However, it seems like tongue tie is a topic frequently discussed in the UK, but not in other countries. Any thoughts or insights on that? That's very interesting for me to hear, actually. I don't know about other countries, to be quite honest with you. All I know is that it's becoming something we're more and more aware of here, and we're doing more about it. So I'm sure there was a point where a newborn check was done and people didn't look for tongue ties maybe a long time ago, but it's something that we're really aware of now, especially as pediatricians, GPs are really aware of it. And a lot of research is being done to see why the incidence of tongue tie is higher now, or is it that we are just more aware of it? So I don't have the exact answer for that, but what I know is that we're being a lot more proactive about it, and what we've seen is that a lot of babies, their feeding does drastically improve straight after. For some individuals, for some babies that have had tongue tie, it doesn't, but for a lot of them it does. So that's what I know so far, so I hope that's helpful. Okay, so I whizzed through the first three, because the first four topics, because the next topic is a really big one. It's reflux and colic, and it's something that a lot of us will sort of hear about and worry about, and we're not sure if our little one has that or what they're going through. So I wanted to explain the difference between colic and reflux, and then I wanted to give you a bit of a guide so you knew if that was what your baby was going through. So colic has a very distinctive definition. I will read it out to you. So it's excessive, inconsolable crying that begins and ends for no reason. It lasts for at least 3 hours a day, at least 3 days per week for at least 1 week. In an infant up to 4 months of age with no faltering growth, which means that they're growing okay, they don't have issues with growth. So what does that mean? That means a lot of crying. It happens for a good solid few hours. Usually tends to happen late afternoon, sort of evening time. I have been there. I've been the mum of a baby with colic. I wouldn't wish it upon anyone. It is really difficult. And so I'm going to answer some commonly asked questions and then explain how you manage colic in your baby and what's good for them. So it does start, as I mentioned, quite early on, so in the first few weeks of life. And it should go away by about 3 to 4 months. And the explanation for that is just time. Time is really the biggest problem solver for colic. Unfortunately, there isn't any sort of magic way to get rid of it. We don't know what causes colic. There are there's lots of speculation, but we don't know. And how is it diagnosed? So there's no sort of blood test or, a piece of equipment that can scan your baby and say they've got colic. It is done by a full examination, a full history taking, and a feeding assessment. So the reason why is because colic is more so a diagnosis of exclusion. So we're looking to see whether there's anything else going on that isn't colic. So is there reflux? Is there CMPA? What else is going on? Does it affect formula-fed babies and breastfed babies in the same way? Absolutely. There's lots of speculation there about it affecting certain babies that are fed in a certain way differently, but it's equal. It's equal between breastfed babies and formula-fed babies, and it's equal between both sexes. So that's a good thing to know. How do you manage it? So movement's really good. So if your baby's crying, during that crying spell, try and rock them. You could put your baby into a pram and push the pram back and forth, or if you've got a crib, that's a bit of a rocker. So that gentle swaying motion really helps your little one. Other things like white noise are very good. You could use something like a hairdryer, obviously away from the baby, or even a vacuum. I know lots of people that have used all sorts of things like that. There are lots of machines now that people tend to purchase white noise machines that can be bought. So that's another option. And a warm bath can be very soothing for a baby with colic. So another thing which I'm going to go into with reflux as well is winding your baby well. That really does help with colic. So winding during feeds and winding after feeds. And look after your own well-being. If you're with a baby that's crying non-stop, it will take its toll on you, on your mental health. It just will. There are no two ways about it. I know lockdown's been really tough in terms of support. I've talked about feeding assessment. I'm sure lots of you have said, I thought, well, I can't get one, or, it's not as easy. It's the same here. You need support, and I know it's not easy right now. But if it's a matter of, you saying to your other half during a crying spell, like, this is getting too much, I just need to go outside, get some fresh air, please can you just deal with this for a bit and I can come back. Because if you try and do it all, and if you're always with that baby that's crying, it will have a really negative impact on your mindset and you will start to feel quite low. So it is known to have that overwhelming impact on mothers, because no one wants to hear their baby cry for that long and not be able to do anything about it. It's very, very difficult. Let's talk about cranial osteopathy, anti-colic drops, probiotics, and dietary elimination. Those are all things people suggest for colic. Where is the research? There's not much research behind it. As a healthcare professional, I'm not going to say anything. I'm not going to say use it or don't use it. You have to do what's best for you as an individual, what's best for your family. Just always be safe and read into it. Talk to other mums, see what they've done. But the main thing is the conservative measures that I've mentioned that really do help, and time and support for you as a parent. That's really important. Okay, let's talk about reflux. So why does reflux happen and why is it so common? So reflux is because your baby's digestive system is a bit immature. You've got your food pipe, which then connects to your stomach, and there's something called a sphincter, which allows the food to come out, and it should close and open. Sometimes it doesn't close, and the milk, which is obviously a liquid, can go back the wrong way. So instead of going down into the stomach, it goes back up the food pipe, and it can go all the way up and come out. So that's when you see milk coming out, so possets. Reflux is really common. Around 40% of infants have reflux, and about 90% of them don't need any sort of treatment for it. What's important is that a small proportion have something called gastroesophageal reflux disease. What does that mean? That means this is happening, the milk is coming out, but it's really causing discomfort. They are crying, they're irritable, it's painful, it's not nice. It means that the feeding is impacted. They don't want to latch. When they come off, they're really unhappy. Things like back arching can occur, hiccups. It's generally just a very unpleasant feeling for your little one. Sometimes so much so that it can lead to what we call faltering growth, which means they lose a bit of weight. Sometimes reflux babies don't lose weight. Jason was one of them. So he had reflux, he did not lose weight with it. He drank milk for comfort because it was a really horrible feeling coming back up his throat, and he was drinking milk to help soothe him. So he didn't lose weight. So a learning point for me as a healthcare professional and as a mum was that you don't just look at a baby with reflux and say, well, they're not losing weight, so they're fine. We look at the whole picture. Jason had hiccups, he had irritability, he had back arching, he had coughing, you name it. If you put him flat on his back, he was very, very unhappy. Now, this brings me to silent reflux. What is it? This is the same thing. The milk, the feelings of discomfort are present, but the milk is not coming all the way up and out so that you can see it. So the possets and the regurgitation that you would maybe expect with a reflux baby are not happening, which is why it's termed silent. But it's far from silent because your baby is quite uncomfortable with it. So they'll be experiencing discomfort and showing you signs of that, whether it's crying or being fussy and irritable. So that is what silent reflux is. And usually babies with silent reflux gain weight normally again. So that's another thing to just remember. Okay, what can you do in terms of conservative management for your baby with reflux? So there are a few things. If you're, this is easier if you're formula feeding to control actually, but you do smaller volumes of feed at more frequent intervals. So just say, for example, you're doing 100 mils every 3 hours, you try and break that up and you do 40 mils every 2 hours or something like that. Those are just numbers, they don't necessarily apply to your baby or age, but it's the concept of having little but often, because that means that they don't get so full that with big feeds that it all just comes up again and is very uncomfortable for them. Another little trick is winding during the feed. So if you're breastfeeding and you're going from one side to another, before you switch sides, in between, I like to do this sort of winding method where, so your baby's flat, maybe on your lap, your index finger and your thumb make a C shape. So you're supporting that neck and the muscles there, and you're just rubbing like that, up and down and patting gently. You don't need to pat really hard to get wind out. That's not going to help. So wind during feeds and after feeds. Another thing we advise is to keep your baby upright for a half an hour post feed. Now, I was shattered. I was feeding, my arms were hurting and I had pillows underneath them. And then I was being told to keep my baby upright. I didn't want to. I was so exhausted. I just wanted to put, Jason down after those feeds. I would recommend getting a sling. It's really, really helpful. So you can just get up, go to the toilet, make some food. You're putting baby next to you, so this part of their body is upright, which means gravity is helping that milk stay down and go down. They're next to your skin, so they're getting comforted. So if they're feeling irritable after that feed, they're next to you, and it's really, really important. And also you can try feeding upright. Now, if you're breastfeeding, it could be difficult to begin with to establish breastfeeding anyway, but if you're breastfeeding, you can breastfeed like this. I'll just move the screen a bit. So it's upright. It's really not the easiest thing to do, and your health visitor should hopefully show you and help you. If you're formula feeding, you can use your elbow, you can give that support there, and you can keep this part of their body a bit more upright when you're doing the feeds. So that's what I would recommend. If you're noticing with the conservative management techniques that I've just explained, that is having no impact on your baby and that reflux is still present, they're still very, very uncomfortable. There are things called feed thickeners. So Gaviscon is a name that lots of parents have heard of. It will help with thickening breast milk, for example, and formula feeding babies may be given something called Carabel. So those are thickeners. They keep that milk more in position in that stomach where it should kind of stay down. If that does not help, then there are medications such as omeprazole or lansoprazole. Jason is just over 2 years old. He has just been weaned off his lansoprazole. He was on a very significant dose, and it took us ages to figure out that it wasn't just reflux, it was CMPA that he had. Because he was on such a significant dose for so long, we had to wean him. I think we've been weaning him for maybe 4 to 5 months now, ever so slowly. So it's not a treatment that you ever go onto lightly, because it requires weaning at the end of it. But what your GP should do, because this is all under medical guidance, bear in mind the feed thickeners and the Gaviscon, the omeprazole, all under medical guidance. There should be a trial. So a trial of the medication to see if it has an impact, to see if it's working before you carry on using it. It should always be under your GP or a specialist for those medications. Okay, I've mentioned CMPA so many times. CMPA symptoms can mirror reflux symptoms, which is where we got called out. Jason has non-IgE mediated CMPA. So what that means is that his reaction to milk, so his dairy allergy, is very delayed. So it happens 72 hours post. We had no idea when he was very little that it was the milk causing him all this trouble. We just thought he had reflux. So if you try all those things and you try reflux meds and still your baby's not quite right, a diagnosis of CMPA should be considered. You shouldn't just go ahead and exclude dairy from your diet on your own. You should try and always do it under guidance, so whether that's a dietitian or your GP, because it's important as a nutrient for you and for your baby. So just bear that in mind, that it is tempting to just say, I'm not going to have dairy, hopefully this will solve everything. But just do it with some medical guidance and bear that in mind. Okay, that is reflux. Are there any questions with reflux? Not that I can see. Put that to one side. So the last topic, I don't know why this is my favourite topic, but it's newborn vomit and stool. And I think it's because I get sent so many pictures of fluids, especially nappies, actually, with mum saying, is this normal? Is this right? And there's so much information there that you can gather from those fluids. So it's a very good topic to just know a little bit about. Babies vomit, they just do. It might be because they're crying a lot, or they're having a coughing bout, a coughing spell, and they're just, they're bringing up milk because of that, or they just work themselves up. So I'm going to talk through the different causes of vomit and why they can happen. I can see it's 5 to 2, so I'll be as quick as possible. So reflux, as we just talked about, can cause something called posseting or regurgitation. So posseting, what does that mean? How is that different to vomiting? Posseting is about teaspoon volume of milk coming out. It's usually quite milky, curdled, it looks milky, it smells like milk. And it's usually small, so a baby can posset up to 6 times a day. That can be very normal. Vomits that we are a bit more concerned about are larger volume vomits that are forceful. That's known as projectile vomiting. And that could be because there's a sort of blockage somewhere going on, especially when they're a newborn between the ages of 0 and 3. If something's going on there, we want to see you, because a baby should not be projectile vomiting like that. It can happen with other things. So vomiting can happen with infections. We talked about a urine infection earlier, and vomiting being one of the sort of symptoms associated with urine infections. It could happen because of a tummy bug. It could happen, where you might see a rash or diarrhea. So all sorts of infections can cause vomiting, and you might see that associated with the temperature, so you know this is a bit of a bug, this is what's going on. Okay. Food allergies and intolerances. I know I'm not talking to babies that are parents of babies that are 6 months and above, but when it does come to weaning, you might end up giving something that your baby then has a reaction to in the form of a vomit. So our personal example is Jason was given green beans, and an hour later he projectile vomited. It was green, which is a red flag, by the way, for later that I'll mention, but it was green with sort of like a food stained green. So I knew it was that green. And also he was above the age of 6 months. So I spoke to a dietitian. She said that's an instant reaction to a food group. Leave that food group alone. Come back to it later. So that's like kind of in a nutshell what things could cause vomiting in a baby. But in a baby under the age of 6 months, 2 things to remember. If you see green vomits, and if there is any sort of projectile vomiting, that's not okay. That's not normal. We want to see you in A&E because something's going on there. Okay. Blood in vomit is, again, not normal. It can happen sometimes, but it's not. It could be because you've got mastitis or your baby's drinking, but usually it's not a normal thing. So we want to see you. And where vomiting is a sort of a real complication, and what you need to look out for is if your baby's got an infection, for example, and they're vomiting a lot and they're not keeping their feeds in, you're going to end up with a baby that becomes dehydrated very, very quickly. And babies tend to become dehydrated much faster than older kids because they have less of a reserve. So if you've got a vomiting baby who's not feeding, go straight to A&E because we want to make sure that fluids are going in and that baby is hydrated. Okay. So vomiting that lasts longer than 2 days is green, is projectile, is associated with something that's just not quite right, like a fever, and your baby seems very irritable and they're not feeding. Get medical attention for that baby. The last topic is stool. And I wrote a really interesting blog post about stool. And it is because a nappy is a wealth of information. And, essentially, you talk about poo all the time when you become a mum, and you're looking at your baby's stool, and you're celebrating when they pass stool, and you're looking at all sorts of different things that can affect it. And you become a bit of a detective, and you want to know what's going on, what's it like. There is so much information in a nappy, it's unbelievable. Newborn stool ranges from, green to brown, so lots of yellowy, orangey colours. The first stool, now I've got a good image to show you with this. The first stool that comes out is a sort of black, thick, tarry stool called meconium. You'll never forget that stool in your life once you see it. You think it's going to smell really bad, but it actually is odourless, quite surprisingly. And your baby's expected to pass that stool in the first 1 to 2 days of life. After that, when your milk sort of comes in if you're breastfeeding or you've established formula feeding quite well, at about day 3 or 4, the stool tends to have a bit more colour to it. So it looks a bit more green, a bit more yellowy green. And then at about day 5, 6, you can see here, the poos become a bit more yellow. And as you can see in the second 2 pictures, the stool's quite runny, so it's quite loose. And what you find with breastfeeding babies especially is that they tend to have looser, runny stools than formula-fed babies. So how do you know the difference between a sort of runny, normal newborn stool and diarrhea? I get asked that all the time. And what I would say is diarrhea is so loose that it can trickle outside of the nappy down the leg. I know we all talk about punamis and babies like having explosions, but this is really watery. You will not forget it once you've seen it. So it's something to keep in mind. In the first 2 weeks of life, your baby is expected to pass around 1 to 2 stools every single day. And if you're breastfeeding, that could be 6 or 7 poo nappies that you're changing. At 6 weeks, something changes, something happens, and the frequency drops. I remember that happened with Jason, and he went for 7 days without passing stool. Some babies go for 7 days without passing stool at around 6 weeks of age, and they're completely fine with it, and then they pass the stool, and they're not uncomfortable. If your baby goes past 7 days, so it's coming up to 7 to 10 days, go and see your GP. They can maybe give you something to help with what we would then term as constipation. But if they're not passing stool under 7 days and they seem unwell with it, go and see your GP. It does tend to resolve, and it is an age where things tend to change. Other things to look out for is when you're establishing feeding in the first sort of week of life. At around day 2 onwards, you should expect around 2 stools a day, bigger than a 50p coin. If you're not seeing that, it may be that you haven't established feeding properly. So it's just something to be mindful of. What do we not want to see in stool? So we do not want to see any blood. That's not right. We do not want to see, apart from the first stool, which is meconium and quite black, we do not want to see black in the stool. We do not want to see a white, chalky stool. So those are things that shouldn't be there. Mucus is something I get shown a lot of in nappies. If that nappy is green mucus stained for more than 2 days, something's going on. It could either indicate an infection or an allergy. So take a picture and show your GP. But if at any point you're worried about your newborn stool, then just take a picture and show someone. Show a healthcare professional and don't hesitate. Okay, that was a very informative hour and a lot for you guys to take in. I hope it was helpful. If you have any questions, I think I've got a few questions coming through. I'm going to try and answer them now. If you have to leave, I completely understand. But let's try and get through a few of these questions. Okay. So Michelle said, are there any foods which babies shouldn't be given over 6 months? I heard eggs, for example. So actually, that's a really, really good question, Michelle. When you start weaning at 6 months, egg is one of those food groups which is known as an allergen, as well as peanuts, and it's actually really advised that you give those quite early on. The longer you leave it, the more likely an allergy will develop. The earlier you introduce it, the less likely, unless your baby has got very severe eczema, then it would be under a healthcare professional that they are weaning, and those allergens would be done in a different way. So no is the answer. You don't need to stay away from eggs. It's a very good thing to give early on. Very easy to give as well. Get the eggs with the lion stamp. And yeah, definitely introduce those. Olivia, she has asked, can a baby have a temperature that is too low? If so, what would that be? So we talked about the average temperature of a baby being 36.4. So yes, a baby's temperature can be very low. We don't really go into that much in detail because it's usually very high when they develop a fever. They can become what we term hypothermic. That would tend to be a baby very early on in the newborn stage that's not feeding well, so their temperature's dropping. That's a baby that's maybe not being dressed appropriately for the weather, their temperatures are dropping. So yes, the baby's temperature can go low, and those are 2 examples where they can go low. But you hopefully won't be experiencing that yourselves. And it is really important to know about what to do when the temperature is really high as well. Okay. Those are the only questions I haven't answered at the moment. So I'll give you all a second if there's anything else you want to ask, or if there's anything else you want to say. I do have a little poll. Wonder if you could answer it for me. It's just to say how useful you found this and whether you would recommend this webinar to others. This is my first one, so I'm hoping to do lots more. I'm hoping to tackle the next age group, which would be 3 to 6 months, and then carry on that way. And if you prefer it to be more interactive, where your spaces are seen, any sort of, I guess, criticism or tips would be much appreciated. But there's a lot of information, and if you do have any questions, you can always drop me a message on my page. I tend to get back to most people as fast as I can. But yeah, I think it's really important as mums, as parents, to just have the right knowledge, filtered knowledge from a good source, because there's so much out there, from a parent as well that helps, just a few tips here or there, just so we can be really confident when parenting. And I just want to say thank you so much for your time, and I hope to see you guys soon in the next webinar, or another webinar. So I hope you all take care and see you soon. Okay, bye.